All right, like and subscribe if you want more step one questions. Here we go. 65-year-old man has a rough scaly patches on his left ear, persisted for several months. There is no pain and itching, and there's a gritty texture that occasionally bleeds when he's scratching it. He's got a lot of time outdoors, ding ding ding, as a construction worker, and there's a multiple erythematous keratotic plaques with sandpaper-like feel in the helix of the ear right here, and there's hyperplasia of the atypical keratinocytes confined to the basal layer of the epidermis. So which histopath findings could be seen if this progresses? All right, so this person has actinic keratosis. This is when you are in the sun. That's a risk because of his outdoor occupation. He has got rough, scaly plaques on the ears, face, and hands, and this can progress, importantly, to squamous cell carcinoma. Okay, so the correct answer is going to be invasion of the atypical keratinocytes into the dermis. So that's SCC, squamous cell carcinoma. So you have to know that it's first of all, actinic keratosis, and then you have to know that it goes to SCC, and this is the most common complication. And SCC happens whenever the atypical keratinocytes breach the basement membrane and then they invade into the dermis layer. And that causes the local tissue to destruct and metastasize sometimes. And this is going to be a painful ulcerative lesion that's caused by the sun. So let's look at the other answers. Basaloid cells with peripheral palisading. This is going to be basal cell carcinoma. And that's going to have pearly papules with telangiectasis. So that's going to be like this spider-like lesion right here, like these little spider vessels. And that's not going to be hyperkeratotic plaques. And there's a good visual for that in a second here. But here's squamous cell. It looks like that. And then there's basal cell. This is basal cell. The palisading you can kind of see. All right, so atypical melanocytes along the dermo-epidermal junction. This is going to be melanoma. And it looks like this. So atypical melanocytes, melanoma. And parakeratosis with Monroe. Anytime you see the Monroe, that's going to be psoriasis. Here's the Monroe microabscesses here. I believe this is hyperketosis right here. So this Monroe is indicative of psoriasis. And that's going to be silvery scales on the extensor surfaces. They're not going to be the gritty plaques in the sun-exposed areas. So yeah, that's going to be the silvery stuff for the psoriasis with Monroe. Epidermal spongiosis with lymphocytic infiltration is going to be found in eczema or atopic dermatitis, and that's going to have your pruritic erythematic vesicles that's not gritty. So basically we have VSAK that causes SCC, and if the cancer is abnormal, it goes to the deeper layers like the dermis, and it can metastasize. So that's going to be the answer. So hopefully this was helpful. Like and subscribe if it was for more content.